Good afternoon, everybody, and welcome to this year's PSA Research Contest. I'd like to thank all the participants who are attending now and to support their different hospitals. To start the program, let's have the Philippine National Anthem.
Mga kababayan, ang pambansang awit ng Pilipinas. Kayang magiliw, tegas ang sinakanan, alam ng puso, sa titik mo'y buhay. Lupang pinirang, tuyang ka ng magiting, sa mandulupin, di ka pasisiw, sa nagatang tutok sa simoy at sa langit ng pagaw, ay hinatang tula, kawin sa pagkayang minamahal, ang islang ng matawad mo'y tagumpay na nagtitindig, kapituin at araw niya kailan pa may di magtitindig, luman ang araw ng walhaging pagsinta, mo'y langit sa piling mo, ang hindi kaya ng pagkay mga api, ang mamatay ng dahil sa'yo.
Okay, thank you very much. Once again, thank you very much, everybody, for attending this afternoon's affair. I am Dr. Michael Madarang. I shall be your MC for this afternoon. To start off, may I call for to give an opening remarks. We call on the chair of the research subcommittee, chair of the subcommittee on research contest of the PSA. She took her medicine in UST Faculty of Medicine Surgery, residency training in Chonghua Hospital, where she was the chief resident. She served under the Cebu Central Visayas chapter as treasurer, secretary, vice president, and she became the president. And in Chonghua Hospital, she was the secretary from 2016 to 2018, and she's the chairwoman from the 2019 up to the present. She was the PSA Regional Director of Visayas from 2019 to 2020, and she is now a PSA Board of Director from 2020 to the present. And may now call on Dr. Jennifer Frances Rosello to give us the opening remarks. Mayang hapon po, Dr.
Thank you, Dr. Michael Madarang. Good afternoon, consultants and residents. Research is an arena of learning where inquisitiveness and a thirst for knowledge propels one to seek further truths. As men and women of science, there is an insatiable need to analyze, delve into the burgeoning theories that pique our interests, and even challenge widely practiced long-held beliefs. Because of this, the PSA Research Committee annually encourages the youngest of our lot to come up with quality investigative work relevant to the present needs of our specialty. This year is no different, with 5 exceptional papers making the cut. To all the entries, congratulations. Know that you are all considered winners to have even reached this point. We are very proud of you. Through this, we hope more in our community will begin actively pursuing different avenues for research, thus making our society a rich repository of contributors to the further improvement in anesthesia care. Let us listen to the entries and learn together from this worthy exercise. Good luck and God bless us all.
Thank you very much, Dr. Rosello. That's very inspirational, and I hope the contestants will learn more. Now, to give us the rundown of the rules and regulations and the mechanics of the contest proper, as well as to introduce the Board of Judges, may I call on well, uh, she graduated Doctor of Medicine from U.S. State Faculty of Medicine Surgery. She took up residency at the Philippine General Hospital. She finished her MBA, Hospital Management at Psa University. She held several positions in the past. She was the past president of the PSA Southern Tagalog chapter. She was the chairman of the Perpetual Health Medical Center of Las Piñas. At present, she is the chair of the Department of Anesthesia of St. Dominic Medical Center in Bacoor, Cavite. She is the assistant chair of the Department of Anesthesia in San Juan de Dios Hospital in Manila. And she is a board member of Medical Center Parañaque. And at present, she is the PSA Regional Director for Luzon. So once again, for a rundown of mechanics and as well as to introduce our board of judges, may I call on Dr. Carmelita Sandique Lunas.
Thank you, Dr. Madarang. For the mechanics of this oral research presentation, they are the following. Number one, the finalists of this virtual oral presentation were prejudged on the merits of the research paper based on content and methodology. This made up 80% of the total score, while the remaining 20% will account for the outcome of this oral presentation. Second, the sequence of presentation determined by the committee will be in the order as indicated on the invitation. Third, each finalist will have 8 minutes to deliver their presentation with 6 minutes for question and answer. Fourth, each judge is allowed 2 minutes to ask questions per contestant. A warning signal will be given at the 6th minute. Fifth, points will be deducted for every minute or fraction of a minute over time or as penalty for non-compliance to rules. And sixth, the decision of the Board of Judges is final. And that for our prizes, the winner of the first prize will get 25,000 pesos, while the second prize winner will get 20,000 pesos, and the third prize winner will get 15,000 pesos. There will also be consolation prize of 5,000 for the non-winners. We have 3 judges for this contest, and they are Dr. Jose G. Beltran Jr. He is the founding president of Metropolitan Davao Medical Society Incorporated, president of Davao Cancer Society Incorporated, president, Philippine Society of Anesthesiologists, Southern Mindanao Chapter, a member of the Board of Directors of SOAP Incorporated, and a member of the Board of Trustees, Pain Society of the Philippines. For our second judge, we have Dr. Serafin L. Bernardo V. He is a member of the faculty and Associate Professor 3, UP College of Medicine. He is a member of the Philippine Board of Accreditation of Anesthesiology from 2018 up to present. Likewise, Chairman, Department of Anesthesiology, St. Luke's Medical Center, Global City, from 2018 up to the present. He is also Chief, Section of Cardiothoracic Vascular and Organ Transplant Anesthesia of UPPGH since 2008 up to the present, and former Head, Section of Thoracic and Cardiovascular Anesthesia, Asian Hospital and Medical Center from 2006 up to 2018. And lastly, we have Dr. Emmanuel S. Prudente. He is the chairman of the Board of Judges. He is an associate editor of the Philippine Journal of Anesthesiology. He is a member of the Board of Accreditation of the Philippine Board of Anesthesiology, president, PSA Negros Occidental Chapter. He is a medical specialist for Department of Anesthesiology at Corazon Locsin Montelibano Memorial Regional Hospital. Likewise, chair of the Regional Hospital Research Ethics Review Committee at the same institution, Corazon Locsin Montelibano Memorial Hospital. Doctors, thank you for accepting the invitation to be the judges in this contest. And good luck to all the contestants. Thank you. Back to you, Dr. Madarang.
Thank you very much, Dr. Lunas. Well, I guess we should go right to the meat of the matter, so to speak. So, as Dr. Rosello and Dr. Lunas has mentioned, we have five physicists to present to us today. And without further ado, and for the benefit of our almost 200 participants this afternoon, may I call on to present to us a prospective study on perioperative patient satisfaction of patients undergoing elective surgery from March to June of 2021 using the ASA patient satisfaction questionnaire. Sorry. May I call on Dr. Roland Cajoles. Dr. Cajoles, take the floor, please.
I will just share my slide po, doctors. Patient satisfaction is and has always been an important subject for healthcare managers and has been widely used metric for measuring the quality of healthcare. Good afternoon, I'm Dr. Roland Cajoles, and I'll be presenting my research entitled A Prospective Study on Perioperative Patient Satisfaction of Patients Undergoing Elective Surgery from March to June 2021 using American Society of Anesthesiologists Patient Satisfaction Questionnaire. The general objective of this study is to determine the level of patient satisfaction undergoing elective surgery in a tertiary hospital from March to June 2021, with the specific objective of determining the factors that affect patient satisfaction in the perioperative period of elective surgical patients as follows. Analytical cross-sectional study design was utilized that would identify the different factors affecting the levels of patient satisfaction. A written informed consent was taken from the respondents. Survey questions from the questionnaire formulated by the American Society of Anesthesiologists and its Committee on Performance and Outcome Measurements was used for the survey. The questionnaire adapted was translated into Filipino by an expert in the Filipino language from the Centro ng Wikang Pilipino, University of the Philippines, Manila. Upon professional statistical advice, pilot testing was not done as adapted questionnaire was already validated. And this is the actual survey form used. The minimum sample size required to determine the proportion of patients satisfied with anesthesia care was computed using the equation below. The minimum sample size requirement for the study was estimated to be 285 patients. The study employed a convenient sampling design to select study participants. All patients who satisfied the inclusion and exclusion criteria were invited to participate in the study. And these are the inclusion criteria and the exclusion criteria. Data were encoded in Microsoft Excel, and Stata NP version 16 software was used for the data processing and analysis. Independent t-test was used to compare continuous variables, while chi-squared test was used to compare categorical variables. In order to determine the factors associated with satisfaction, multiple logistic regression analysis was performed with backward elimination technique. P-values of less than or equal to 0.05 were considered to be statistically significant. And this is my study flowchart. A total of 392 patients underwent elective procedures under anesthesia during the study period. Among these, a total of 294 patients were included in this study. Breakdown of age group is shown in this diagram, and majority of the sample population were noted to be of 25 to 34 years of age. 20% were college graduates, 7% were able to finish vocational studies, 51% were only able to finish high school, and 22% were high school undergraduates, elementary graduates, or undergraduates. 45.5% were operated upon regional anesthesia, and 36% were operated under general anesthesia. The rest were anesthetized with different means. 95% of the participants perceived their health condition as very well. These are preoperative satisfaction ratings to specific satisfaction questions compared to one another, showing that patients were satisfied with the anesthesiologist's care prior to operation and after the operation. This table presents a demographic and clinical profile of patients. Since the data collected was not normally distributed, median was used. Median age was 39 years old. Most were from the 25 to 34-year-old group, and majority of the participants were females. About half of the patients attained a high school level of education. Spinal anesthesia and general anesthesia were the predominant anesthesia type used. Most patients reported very good, and excellent overall health, and 178 or 61% experienced pain during or after surgery, in which majority of them, or 84%, only had a mild level of pain. Except for 5 patients, almost all patients were aware that the anesthesiologist administered the anesthesia during surgery, as seen on this table. All patients mentioned that their anesthesiologist encouraged them to ask questions. However, only 66% did ask questions to the anesthesiologist, which all reported that the anesthesiologist answered the questions clearly. All patients reported that the anesthesiologist visited them before their surgery, and talking with the anesthesiologist during the visit definitely made 83% of patients feel more calm and relaxed. Median rating given by the patient to the anesthesiologist was 10. A perfect rating of 10 was given by 55% of participants, and a total of median satisfaction rating of 87.22% was concluded, with 36 or 12% of patients actually had a 100% satisfaction rating. Factors associated with perfect satisfaction rating was explored in this table. Of the demographic and clinical characteristic tested, only the following factors were found to be associated with 100% satisfaction. Patients with vocational level of education had 6 times higher odds of 100% satisfaction rating compared to patients with primary level of education. Patients who receive spinal anesthesia alone or in combination have 10 times higher odds of 100% satisfaction rating compared to patients who did not receive spinal anesthesia. And patients with mild and moderate level of pain during or after operation have 6 times higher odds of 100% satisfaction rating compared to patients without pain, which is probably due to prompt and effective management of their symptoms. In conclusion, the result of this study suggests that the factors that explain patient satisfaction most significantly was the resolution of post-operative symptoms and or absence of it. A good pre-operative visit and successful management of post-operative complications were enough to provide favorable patient satisfaction in doing a post-operative visit. And lastly, aspects mentioned in the study that could affect patient satisfaction includes patient anesthesiologist rapport or understanding, proper perioperative planning, good pain control, and management of anesthetic side effects. With that, thank you for listening and have a good day. Thank you.
Thank you very much, Dr. Cajolas. And now may I call on to start our Q&A, I call on the chairman of the Board of Judges to start questions.
Okay, thank you, and congratulations, Dr. Cajoles, for your paper. No? First of all, a comment lang. No? I have to disagree with the advice given to you by your statistician. No? I think you should still do some validation study with regards to the use of your tool, because it was developed using American subjects in consideration. And our Filipino, you're from a government hospital, right?
Yes, sir.
Your patients might have a different view on what constitute good patient satisfaction. No? So, and if you pre-tested your paper, you might have catch on that you used as a question regarding race, and you asked if they were Black, Latino, Hawaiian, or Alaskan, which is actually inappropriate for your patients. No? So my first question is, you mentioned in your methodology that you use a summary score of 95 being the highest, correct? So you assigned scores per item, 5 or 6, according to the Likert scale, and you had a summary score of 95.
Yes.
I guess you used it because one of your goals was 100% satisfaction, and you reported a median rating of 80 something. No? So my question is, did the original ASA patient satisfaction tool used a summary score?
Um,
And
no,
if they did, what was the cutoff for saying that the patient has patient satisfaction?
um, I actually, sir, I really don't know if there is a universal rating as for example, in our hospital, we are the ones who set the percentage of level of satisfaction. Like in our institution, we set it to 85%. The goal, this is the goal in making a strategy in performance governance system. So we are the ones who set the level of satisfaction
That's
to
okay, no?
be favorable at 85%, sir.
That's okay, but you have to consider that when you're adapting a tool, you have to use it the way they intended it to be used, no? So if they did not set a summary score, don't use a summary score, no? Uh, Kasi, for example, you said you based your 95 score based on 19 items, but your survey questionnaire actually comprised of 30 to 33 questions and not 19. So I don't know how you got the score of 95. Okay, second question is, based on your results, what are the dimensions or domains of your questionnaire that contributed most uh, in the patient satisfaction of your patients?
The domain, sir, that actually contributed to that was the preoperative visits, the uh, the how the anesthesiologist provided relief to their agony, and also um, for those who experience pain and post-operative symptoms like nausea and vomiting, on how it was managed. So those two, sir, contributed the most to the satisfaction ratings.
You mentioned pain management and the provider-patient relationship. No, those
Yes,
if you look at your original ASA tool, they identified the dimension as decision making, involvement in decision making, pain management, attention, provider-patient relationship, and anesthesia-related sequelae. No, so I encourage you to read the actual ASA tool. Thank you.
thank you, sir.
Thank you very much, Dr. Prudente. For our next judge to ask questions, may I call on Dr. Jose Beltran.
Good afternoon, Dr. Cajoles.
Good afternoon, sir.
Based on the result of your study, it seems that there is a difference on the on the satisfaction rate on the based on the educational attainment of the subjects. No, you mentioned that those in primary has apparently higher satisfaction than those on college or vocational. Can you cite the reason behind?
With that matter, sir, I pointed it out as a statistical result based on the data that I was able to gather. But with specific reasons on how did that come up, um, I think I really cannot say on behalf of the participants, because they were not provided with comments, sir, that they can actually write on. But if I'm gonna make an assumption on why would that be, because probably yeah, in the province, we can say that the level of satisfaction in patients has a kind of selective bias. Like if we have attained a higher level of education, um, we tend to be very particular on what kind of healthcare that we are getting. But for the population that actually were not able to have higher education, probably because of their status in life, they are easily they can easily be feel contentment even on how little healthcare you have provided them.
I have a next question pero 2 minutes na kasi. Sorry. Next na lang.
Thank you very much, Dr. Beltran. Next na kami kung tanongin kung may time pa po mamaya. Lastly, may call on Dr. Serafin Bernardo for his set of questions.
Hi, good afternoon, Dr. Cajoles. So actually, my first question was related to the question of the first judge, no? With regards validation of questionnaires, no? Normally, when we conduct questionnaires like this, we test pilot it or test run it before we. It's not enough that a professor will just validate it, no? We usually run it and test how valid are the questions are. Okay. My question is, how did you conduct the survey again? Is there a particular person who conducted the survey or just different residents conducted this? And this was on a face-to-face or a paper questionnaire?
The residents, doctor, performed them as they served as my research assistants. We conducted it using paper survey, sir, because initially this research was proposed using a electronic device or a tablet, and will be using a Google form. But then upon reassessment of our technical and ethics committee, at that time they discouraged it due to health reasons, sir. So they we thought that the paper questionnaire would be safer for everybody. So.
Okay. So do you think there will be a bias if you do it on a face-to-face compared to hard copy survey form evaluation of your patient satisfaction?
To be honest, sir, I think that there will be even a little, yeah, there will be a bias with them as the patient is directly facing the one that is conducting the survey. So yeah, there might be a little bias there.
Yeah, because based on the experience, you know naman how patients who are admitted in government hospitals are more kind and more nurturing to their doctors compared to the patients who are admitted in private hospitals. Okay, thank you very much, Dr. Cajoles.
Thank you very much, Dr. Bernardo, for your questions. The fans of Dr. Cajoles can now rest on your lap. We can now go to our next presenter, who will be presenting to us her paper on left head rotation as an alternative to difficult tracheal intubation. So may I now call on Dr. Danya P. Chan.
Tracheal intubation is a life-saving intervention. Optimizing the patient's head and neck position for the best glottic view is a crucial step that facilitates a quick intubation. Difficult intubations may present for experienced and inexperienced physicians, which may result in aspiration, esophageal intubation, and prolonged hypoxia. There are several positions used for intubation. The sniffing position has been preferred and is the current gold standard to visualize the glottis with a successful first attempt at intubation. Studies claim that the sniffing position did not improve glottic visualization nor success rate on intubation. This led to various maneuvers challenging the sniffing position. The left head rotation maneuver, or LHR, is a simple novel approach for difficult airway introduced in 2019. Using LHR has been proven successful after more than a single attempt at intubation using various methods. When the patient's head is turned to the left, the esophagus will be compressed by the trachea, making the intubation easier. This non-invasive maneuver can be the best alternative before proceeding to a surgical airway. This study assessed the success rate of intubation of patients in the Leher versus sniffing position. Specifically, it aims to answer the following questions. Cormac-Lehane is a grading system commonly used to describe the glottic view during direct laryngoscopy. Intubation difficulty scale is an objective and comprehensive assessment of the difficulty of intubation based on the number of attempts, number of operators, number of alternative techniques used, the glottic exposure, lifting force, the use of cricoid pressure, and vocal cord mobility. A score greater than 5 represents intubation with moderate to major difficulty. In this study, successful intubation is defined as presence of capnographic waveform and less than or equal to 2 attempts at intubation. This is a randomized open-label clinical trial. Enrolled participants were scheduled for elective surgeries requiring intubation. A standard airway evaluation was performed. Once the patient meets the inclusion criteria, consent was secured during the preoperative assessment. Randomization was done via draw lots. There were 26 allocated participants for each group. Group A were intubated using Leher, while Group B were intubated using the sniffing position. Cormac-Lehane grade and the intubation difficulty scale, or IDS, were graded after intubation. And if the intubation is unsuccessful after 2 attempts, an alternative position was performed and the same scoring applied. The study ends after a successful intubation and the intended surgical procedure will proceed. So for the results and discussion, most participants were 54 to 65 years old. Sex distribution favored males. And 50% of the subjects had normal BMI. The analysis did not show any significant statistical difference between the two groups in terms of age, sex, and BMI. This graph depicts the relationship of Cormac-Lehane and the two positions. Majority were Cormac-Lehane grade 1. The relationship between Cormac-Lehane and the two positions was statistically not significant. It is worth noting that while my study included patients who have Malampati 3, which is an established predictor of a difficult intubation, only 8 out of 52 patients had a Cormac-Lehane grade of equal or more than 3. This graph breaks down the intubation difficulty scoring. When the patients were intubated in the Leher position, the anesthesiologist had more than 1 attempt at intubation, more than 1 operator, and they used a stylet as alternative technique. Even if the results are not statistically significant, there was an increased lifting force and increased use of cricoid pressure when the patients were intubated in the sniffing position. This graph describes the relationship between the IDS and the two positions. Most patients were intubated with slight difficulty. There is no statistical significance between the IDS and the two positions. So there was a study comparing the ease of intubation between 200 obese and lean patients. Among 9 patients who had a Malampati 3, only 2 had an IDS score of more than 5. So our findings also conclude that Malampati test, when used alone, is a poor predictor of difficult intubation. There was a 100% success rate of intubation with sniffing position. On the other hand, only 24 out of 26 were successfully intubated in Leher. This is an analysis of the 2 failed intubations with Leher. Had a Cormac-Lehane 3 and an IDS of 7, despite the use of a after 2 attempts. After shifting to the sniffing position, Cormac-Lehane improved from 3 to 2 and IDS from 7 to 3. The second patient had a Cormac-Lehane 4 and an IDS of 8. Despite the use of stylet, cricoid pressure, change of operator, and additional lifting force, the patient's airway was not secured. After shifting to the sniffing position, the Cormac-Lehane improved from 4 to 1 and IDS improved from 8 to 2. The difference here is big, and it's possible that this is an incidental outcome. The study size is small, and this is not enough to make a conclusion that Leher is not effective. The clinical experience may have played a role in the assessment of intubation. So senior residents and consultants were oriented with the research and both had limited experience with liver. During the first attempts, some awkwardness was noted as they performed liver. In conclusion, this study revealed that sniffing position provide a higher intubation success rate since there is better laryngeal exposure and intubation ease compared to the left head rotation. However, the generalizability of our study's outcomes needs to have a larger number of participants to provide a credible comparison. Since the sniffing position is almost always the default approach, we recommend doing simulation training of Leher among practitioners to provide greater familiarization. Lastly, Leher can be performed continuously and challenges can be documented to improve intubation conditions. Thank you very much and good afternoon.
Thank you very much, Dr. Chan, for that presentation. Now, may we call on, at this time, we'll call on Dr. Jose Beltran to start our question and answer.
Good afternoon.
Good afternoon, sir.
I believe you use a video laryngoscope for intubation.
No, sir. We used a standard laryngoscope. So we used a direct laryngoscope during the data collection.
Okay. What would just in case the laryngoscope, direct laryngoscope, will fail? What other options do you have?
During the data collection, sir, we already, our institution already acquired a video laryngoscope. So in the case that the intubation fails despite the shifting of the positions, the standard treatment of a difficult intubation based on the ASA difficult airway algorithm will still be applied, sir.
Okay. That's my only question. Thank you.
Thank you, sir.
Thank you, Dr. Beltran. May we now call on Dr. Bernardo for his questions? Dr. Bernardo.
My question is, since you're comparing two techniques, why are you using different operators, which will provide more variable in terms of testing the efficacy or effectiveness of a technique? Why not doing the intubation on different patient by a single operator?
I guess, sir, that was one limitation of my study since there were obvious reasons for inter-observer variability. So I guess we could propose another study using only one operator.
Yes, because we try to, if you're comparing a technique, it's better to standardize or make your variables as few as possible. The training of the anesthesiologists and the level of expertise will play a role in terms of performing a technique in anesthesia. Okay, thank you.
Thank you, sir.
Thank you very much, Dr. Bernardo. Now, we call on Dr. Prudente for his set of questions.
Good afternoon and congratulations, Dr. Chan, especially for picking up a research idea from a case report. No? But to be fair, no, this case report was reported in BMJ case report. My question is related to Dr. Bernardo's question. You have, in any technique, you have some learning curve. So did you train or your operators with regards to Leher before you started your study?
During the before we made the data collection, sir, we failed to simulate the Leher on on a model. So that was part of the limitations of my study also. Since the instruction or the process of doing we only try to rotate the head to the left at using 45 degrees. We assume that we can perform it very easily. So one limitation of my study was, yes, the clinical experience should have been that we tried to simulate numerous times before doing the research, sir.
So yes, I agree with you, Judo. The point here is that it's unfair for the Leher group, no, if your operators are not yet proficient with the technique. So you have to train them first and be proficient with the technique before you compare it with the standard intubation, no. Do you think that I'm in favor of doing simulation first for in terms of patient safety. But do you think using an airway mannequin will simulate the anatomic changes that a rotation of the head will produce in an actual human?
Uh, it will be hard, sir, but I think with continuous practice, I think we can perfect the maneuver if we try to continuously apply leher with our mannequin, and also we can also try her with our simple patients, those patients who can be easily intubated also, sir.
Yeah, I agree with that now because my reservations with the mannequin is usually 'di ba stiff yung tissues niya, no? So it will not fall based on gravity and what you can simulate actually is the angle of the rotation because some of the papers that describe this technique proposes that you rotate the head more than 45 degrees, correct? And some will say that with less
Yes.
than 40 degrees rotation it will not help, no. So yung masanay lang ang operator to get the optimum angle of rotation can be helpful. Thank you.
Thank you po, sir.
Thank you very much, Dr. Dente. Thank you very much, Dr. Chan, for your presentation. Now, our next presenter, I'm sure, is excited to present her paper. So, without further ado, to present to us the performance on Minicog screening test as a predictor for postoperative complications in older orthopedic surgical patients admitted in a tertiary hospital, February to October of 2020. May I call on Dr. Cheryl Joyce Tan. Dr. Tan, your floor, please.
Just hold it, Dr. Chan, ha?
no presentation will be complete without a little bit technical difficulties.
Thank you, Doc. Both in terms of incidence and associated adverse outcomes, perioperative brain dysfunction is as serious as the other varieties of organ system dysfunction for which we routinely screen and evaluate surgical patients. Why then don't we routinely assess cognition preoperatively? Good afternoon. I'm Dr. Cheryl Tan, and I'm here to present my research entitled Performance on Mini-Cog Screening Tests as a Predictor for Postoperative Complications in Older Orthopedic Surgical Patients Admitted in a Tertiary Hospital from February 2020 to October 2020. Cognitive impairment is common perioperatively. This is a particular problem in elderly with 30 to 80% developing delirium after major surgery and 30 to 40% and 10 to 15% having early and late post-op cognitive dysfunction, respectively. This is associated with adverse surgical outcomes, longer hospitalization, higher resource utilization, and higher mortality. The American College of Surgeons and the American Geriatric Society have suggested that pre-op cognitive screening should be performed in elderly surgical patients. However, formal and routine pre-op cognitive evaluation is not yet implemented in most medical centers. The study will benefit health professionals by guiding management decisions and development of hospital protocols on perioperative geriatric care, and ultimately, the patients. Comprehensive geriatric care can then be targeted to those identified as at higher risk and hopefully improve surgical outcomes. Here are the general and specific objectives and the multiple limitations of the study. Hip and knee replacement are among the most common procedures performed on patients more than 65 years old. There is intense interest in identifying predictors of adverse outcomes in this age group, as they have a high complication rate and often do poorly post-operatively. As a result, geriatric management protocols now increasingly incorporate pre-op cognitive screening. Cognitive deficits are often subtle and missed by casual observation. In a US study, the prevalence of dementia increases from 5 to 40% with older age, even higher if milder forms of cognitive impairment are included. On patients for elective hip replacement, 20% have cognitive impairment. Previous studies reported that poor pre-op cognition is associated with greater post-op complications and that a low pre-op mini-cog score predicts adverse outcomes in older surgical patients requiring post-op ICU care. Unresolved is whether pre-op cognitive screening can help identify those at risk for an adverse outcome when the procedure is common and elective. There are yet no evidences to support that targeting these poor cognitive performers for multi-component intervention improves surgical outcomes. But recent literature suggests that interdisciplinary communication, rehabilitation, specialized units, and comprehensive geriatric care may enhance outcomes of surgical patients. As illustrated in this framework, preoperatively, mini-cog test performance, demographics, and clinical profile of eligible patients were looked at. Then, post-op complications were observed with the aim of determining the relationship of mini-cog performance to these outcomes. This is a prospective cross-sectional study conducted at a tertiary hospital on patients more than or equal to 65 years old who were scheduled for hip or knee replacement between February and October 2020. This group is selected because lower extremity joint replacements are relatively homogeneous, do not share a risk factor with cognitive impairment beyond age, and do not affect the CNS directly. Those with prior diagnosis of dementia, planned outpatient surgery and ICU admission, known CNS pathology, limited vision, hearing, or ability to draw, and those who can't understand English, Filipino, or the local dialect were excluded. It is important to distinguish that delirium is an acute reversible condition with a fluctuating course, while dementia is a combination of cognitive deficits that are chronic and non-fluctuating in nature. Demographic, medical, and functional data were gathered using the existing institutional pre-anesthesia assessment form. Outcomes investigated included delirium, hospital length of stay, mortality, and non-cognitive complications. Patients were cognitively screened using the minicog. This involves a 3-item recall test for memory and a clock drawing test. The minicog is validated in community-based populations, has minimal bias, high sensitivity and specificity, and good inter-rater reliability. 5 is considered a perfect score, and less than or equal to 2 is considered probably impaired. Accordingly, this was used as a cutoff score. Delirium was identified both by chart review and by direct independent assessment using the confusion assessment method. A diagnosis of delirium requires the presence of an acute onset of mental status changes and inattention, and either disorganized thinking or altered level of consciousness. Qualitative and quantitative data were summarized as rates and proportions and arithmetic mean with standard deviations, respectively. Poor pre-op cognitive score is low educational attainment. Advanced age, sex, BMI, ASA status, ADL, operative diagnosis, and type of joint replacement procedure were not associated with adverse outcomes. 18.2% of elderly patients for hip and knee replacement have probable pre-op cognitive impairment. 27% develop post-op delirium. The results show a notable percentage of elderly patients electing to undergo hip and knee replacement procedure have baseline probable cognitive impairment that are previously unnoticed or unrecorded but may be severe enough to affect post-op management. Those with low minicog score were thrice more likely to be positive for post-op delirium. These figures are comparable to the results of recent literatures. However, unlike studies done in specialized units, the relationship of cognitive impairment with non-cognitive adverse events for this demographic cannot be confirmed. As a conclusion, pre-op minicog screening can predict post-op cognitive complication in older orthopedic surgical patients. Lower educational attainment is associated with a poor pre-op minicog score. Among elderly patients for hip and knee replacement, a notable percentage had pre-op probable cognitive dysfunction and post-op delirium. Those with poor pre-op cognitive performance were 3 times more likely to be positive for post-op delirium. Highlighting one of these recommendations, cognitive screening such as the minicog can be a valuable adjunct to traditional preoperative risk assessment practices. Why then don't we routinely assess cognition preoperatively? By now, we should. Thank you.
Thank you very much, Dr. Cheryl Joyce. I now call on Dr. Bernardo for his set of questions for you.
Congratulations, Dr. Tan, for initiating this study. But my only concern here is your sample size.
Yes, Doc.
I know for the fact that you have very limited subjects in this study. And my worry is how can you validly extrapolate your study and based on a very small sample size?
Tan, did you get Dr. Bernardo's question?
No, Doc, sorry.
Yeah, I'll repeat your question. Dr. Tan, thank you for this study. My worry
Yes, Doc.
here, my only comment here is the small sample size of your subjects.
Yes, Doc.
And then how can you validly extrapolate your conclusion based on a very small study group?
Well, as much as we wanted to collect like, about at least 30 samples, doc. So before the pandemic, our estimate was we were able to get at least 60 samples that would clarify the inclusion criteria. But because pandemic happened, fewer patients were admitted for elective surgery, and also for among those who fit the inclusion criteria. So that limitation, doc, was stated in our paper also.
Thank you, Doctor.
Okay, thank you, Dr. Bernardo, for that question. Now, I call on Dr. Prudente for your questions to Dr. Tan.
Again, congratulations, Dr. Ratan. No? I think your paper is one of the better written manuscripts. My first question is, you had two patients who had mini-cog score of less than or equal to 2. Did you consider them as mentally competent or were they incompetent?
Doc, they were mentally competent. They had subtle findings of cognitive impairment that were only seen upon doing the mini-cog exam.
Okay. So the mini-cog...
So they were classified as those having as probable cognitive impairment.
Okay. So mini-cog is a simple test, no? Maybe next time if you want to increase the sample size, you want to consider also using other tests like the mini mental exam, no? Because patients who are at risk of dementia and mental incompetence will have an implication on getting the consent, right? If they cannot decide on if they are mentally incompetent, they cannot sign the informed consent for you. Okay. Also,
Yes.
yeah.
Those that were already diagnosed with dementia, doc, were excluded from the study.
I understand that, no, but sometimes patients will not come in for will not consult for diagnosis of dementia. So the next question actually is, were you able to test these two patients who had less than 2 score in minicog if they already had dementia or no, not delirium, no, kasi it's chronic dementia pre-operatively? Because if that was present pre-operatively and then you saw it post-operatively, baka it's not the operation that's affected them.
We did not do other tests, doc, aside from the mini-cog. We only did chart review and interview with the patient and the SO. So to rule out possible strong factors associated with dementia, we ruled out patients with strong history of Alzheimer's or stroke or previous histories of mga cerebrovascular disease.
No, kasi the use of minicog is not for prediction. No? It correlates well with other tests. No? Last is, you were the outcome assessor. You assessed for post-op dementia using the confusion assessment method scale. Correct. So, were you blinded as to the minicog scores of your patients? Sorry, nakamute kaya.
I was not blinded, doc.
Okay, so that's a possible source of bias, no? So if you want to increase your size, maybe you consider other observers. You can do multiple observers and just settle your difference by a decision tree, your inter-rater variability. Okay, thank you.
Okay, thank you very much, judges, for your questions to Dr. Ratan. The fans of Dr. Ratan can breathe a sigh of relief. Our next presenter, who I'm sure would like to present already, will be presenting on clinical outcome of confirmed COVID-19 patients who underwent an operation under general anesthesia admitted in a tertiary hospital on March 2020 to March 2021. So may I call on Dr. Gabriel Angelo Vista to present to us this case. Dr. Vista.
Good day, everyone. I am Gabriel Angelo Vista, and I will be presenting my research paper entitled Clinical Outcomes of Confirmed COVID-19 Patients Who Underwent an Operation Under General Anesthesia Admitted in a Tertiary Hospital on March 2020 to March 2021. In December 2019, a disease outbreak occurred in Wuhan, China, caused by the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 and has rapidly spread all over the world. One of the Southeast Asian countries has been the pandemic with approximately 444,164 confirmed cases with 8,677 deaths. Elective surgical cases were initially put on hold, but life-threatening cases requiring surgical interventions were still catered, in which some requires general anesthesia, which also carries certain risk on the respiratory function of the patient. Changes to the respiratory system can occur immediately, even at the induction of general anesthesia. Respiratory drive and muscle function are altered, lung volumes reduced, and atelectasis develops in more than 75% of patients receiving a neuromuscular blocking drug. The purpose of this study is to provide local data on the socio-demographic characteristics, clinical profile, ICU admissions, complications, mechanical ventilation requirements, and mortality rate among these patients. This study would help in better scheduling of the proposed operations, guide us in determining appropriate recommendations for a favorable outcome of the patient, implement better preventive measures by awareness and education, and better utilization of health resources. The study aims to determine the clinical outcomes of confirmed COVID-19 patients after surgery under general anesthesia with the following specific objectives. This paper employed a descriptive cross-sectional study design conducted at the tertiary hospital from March 2020 to March 2021. The target population or the patients with their medical records were confirmed positive for COVID-19 and underwent surgery under GA, and involved total enumeration of all these patients. After approval from the Technical Review Committee and Ethics Review Committee, the data collection was started, which involved searching scan charts of the concerned patients using the patient's record database for a chart review and collated the necessary data from each chart using a data extraction tool. Data obtained was encoded and tabulated in Microsoft Excel. 71 charts were included in this investigation. Pertinent data are then tabulated, analyzed, and discussed accordingly. The mean age of patients affected is about 38.53 years old, mean BMI of 23.3 kilograms per meter squared, and predominantly males. For the classification, more patients was noted to be under class 3, with the most common preoperative comorbidity is hypertension. The most common symptoms at COVID-19 onset were fatigue or malaise, followed by cough, then myalgia or arthralgia. These manifestations are non-specific, and anyone presenting such symptoms should be carefully screened due to a high index of suspicion. About 78.57% of patients with chest X-ray and 12.86% with CT scan had radiologic evidence of COVID-19. The routine use of imaging modalities, especially chest CT scan, together with RT-PCR testing, can help screen COVID-19. Patients who will undergo surgery can be highly contagious, with asymptomatic positive patients still having a transmission potential. Neurosurgery was responsible for treating the largest percentages of these patients, followed closely by general surgery. Majority of these patients under neurosurgery require more emergent operations even during these COVID times. Almost all who had surgery under general anesthesia had endotracheal tube insertion as their airway management. This is understandable as it is the best option to do during the time of pandemic by securing the airway for a safe operation. The mean duration of the surgeries while on general anesthesia is 181.9 minutes, which is more than 2 hours, thus increases the risk of exposure. During the disease progression, 4.29% of patients received ICU care with a mean postoperative ICU length of stay of 3.33 days. This may be due to the limited number of days of beds in the ICU, versus a staggering amount of patients admitted in the institution that require ICU admission. After the operation, 76.05% were extubated, 16.9% of which remained intubated postoperatively, and 7.05% reintubated sometime postoperatively. The postoperative intubation rate in this study is 23.95%. This study had a complication rate of 26.76%, with shock requiring vasopressors ranked as the highest at 9.85%. The mortality of patients with COVID-19 was at 11.3%. All of these patients have one or more comorbidities. These patients were further stratified to belong to ASA class 3 and 4. The mean length of hospital stay is 28 days, and this can be helpful in estimating the average cost of each patient contracted with COVID-19 for operation under GA. In conclusion, the ICU admission is low, while the mortality rate, mechanical ventilation requirement, and complications are high. This may entail a connection of general anesthesia in patients undergoing surgical procedures, which necessitates strategies to decrease perioperative mortality and morbidity, infection transmission to healthcare workers, and provide less risky anesthetic techniques such as spinal anesthesia and peripheral blockade. Due to the limited data and knowledge of this disease, this paper was only able to perform a descriptive analysis. Recommendations for further research are the following. And here are my resources. Thank you.
Dr. Vista, thank you very much for that presentation. So now may I call on once again Dr. Prudente for his set of questions.
Congratulations, Dr. Vista, no, for a very timely topic. No? But I think I'll just give my time to Dr. Beltran and maybe ask questions if there's still time.
Dr. Beltran, your questions, please.
Yes, good afternoon. Would like to verify the reason for reintubation of how many patients was that?
For these patients, doc, who are reintubated postoperatively, they had a these patients were already in a poor condition due to their preoperative medical complication or disease, and postoperatively they had a difficulty in respiration, doc, or in ventilation. Thus, they were intubated after, doc, or sometime postoperatively, doc. So they were intubated at the ward, na, doc.
At the ward or at the ICU?
Sorry, doc. Some of these patients were in the ward, doc.
Was the intubation immediately post-op or?
No, doc. No, doc. A few days after, doc. The operation, doc.
Okay. That's all. Thank you.
Thank you, doc.
Okay, thank you, Dr. Beltran. Dr. Prudente, do you have your questions ready, or can we proceed to Dr. Bernardo?
No, I'm just worried that I'm taking.
Just one comment lang. Just one comment lang. Thank you, Dr. Vista. No? Did you try to? I know this is a descriptive study. No? Did you try to make a comparative study with another institution or from other countries, comparing your observation?
Thank you, doc, for the suggestion, doc. So, for my study, doc, I was really thinking of making a comparative study, but because of the limitation of the data, doc, I was only able to do a descriptive study, doc, because this topic or this disease entity is still in its early, as we say, early phase, doc, or only a few months or a year, doc. So I also researched about a part of my related literature, doc. There were some studies wherein there were comparative studies between doing general anesthesia in patients who are COVID positive and patients who were not COVID positive, doc. So I was planning to do that, doc, but due to the limitation of the data, doc, as well as for the limitation here in our institution, Doc, I was only able to perform a descriptive analysis, Doc.
Thank you, Dr. Vista.
Thank you, Doc.
Okay.
Thank you,
Can I-
Dr. Bernardo. Dr. Prudente, your questions, please.
So that's good, Dr. Vista, that you mentioned that you want to compare it with non-COVID patients. No, also if you can compare it with non-general anesthesia patients, meaning other patients who underwent regional anesthesia. No, so you can compare the effect of surgery versus just the effect of the anesthesia and probably intubation. No? So, and I agree with Dr. Bernardo that this is a perfect protocol to share with other institutions that you can do multi-center studies. No? But you want to have more information since this is just a cross-sectional study. It doesn't really tell us so much unless you specifically look for such factors like because your results said most of those who went to ICU were neurosurgical patients. No, it might not be COVID related. No, it might be
Yes.
just patient factor, the surgery itself. No, so you want to look at pre-op COVID status of your patients. What are they? Oxygen support or airway support at that time. No, and you want to look at outcomes that are specific um, to general anesthesia and intubation, such as atelectasis, barotrauma. I've seen some patients who had subcutaneous emphysema. No, those yung parang you have to look at factors that will affect your outcome rather than just collect data and parang walang masyadong conclusion that you can get. No? Thank you.
Thank you, Doc. For my one of my recommendations, Doc, was to have a multi-centered approach on this research, Doc. So thank you, Doc.
Thank you very much, Dr. Vista. Thank you very much, judges. I can see our next presenter is excited, preparing herself already. So our next presenter will be presenting an RCT, a randomized controlled trial on the efficacy of prophylactic intravenous ondansetron on the prevention of shivering during spinal anesthesia. Interesting. So may I call on Dr. Sara Angelica Yambao to present to us her paper. Dr. Yambao.
Good afternoon po, doctors. I'm Dr. Sara Angelica Yambao, and my research is entitled A Randomized Controlled Trial on the Efficacy of Prophylactic Intravenous Ondansetron on the Prevention of Shivering During Spinal Anesthesia. My general objective is to determine the efficacy of ondansetron 8 mg IV in preventing shivering during elective lower abdominal and lower extremity surgical procedure under spinal anesthesia. And my specific objectives are as follows. First is to compare the core temperature changes of ondansetron and control group after induction of spinal anesthesia and for the whole duration of surgery. Second is to compare the incidence and rate of shivering in ondansetron and control group. And third is to record skin and core temperatures intraoperatively and relate them to shivering incidence. So shivering is an involuntary oscillatory muscular activity that can increase metabolic heat production up to 600% of the basal level. And shivering occurs following general or neuraxial anesthesia with rates as high as 55%. So as we know and see, patients report that shivering is remarkably uncomfortable, and some even find the accompanying cold sensation worse than the surgical pain. Moreover, shivering per se may aggravate post-operative pain simply by stretching the surgical incisions. Shivering occurs primarily in response to core hypothermia, and the normal response to hypothermia involves thermoregulatory vasoconstriction to decrease cutaneous heat loss and maintain heat within the core. Maximal vasoconstriction occurs before thermoregulatory shivering occurs. Now, the interthreshold range describes the lower and upper limits of core body temperature between which no autonomic thermoregulatory effects are triggered. At a core temperature above this range, the body will initiate cooling measures such as sweating and vasodilatation. And at a core temperature below this, vasoconstriction and shivering will commence. Intraoperative hypothermia develops in nearly all unwarmed surgical patients and results from the combination of anesthesia-induced thermoregulatory impairment, cool operating room ambient temperature, and exposure of open body cavities during surgical procedures. But the most important of these factors is the thermoregulatory impairment, since anesthetized adults would otherwise resist surgical heat loss via vasoconstriction and shivering. Now, this table shows the number of dermatomes blocked versus reduction of the shivering threshold. So the shivering threshold was reduced more by extensive spinal blocks than by less extensive ones. Now, the mechanisms of ondansetron on shivering may be related to a central mechanism of the inhibition of 5-HT reuptake on the preoptic anterior hypothalamic region. Ondansetron and meperidine have similar effects on the prevention of shivering without significant association of ondansetron with bradycardia. I chose a single-blind, randomized placebo-controlled study. And for the review of related studies, all publications were searched online, and I used PubMed with the following terms: ondansetron, shivering, spinal anesthesia, and prevention. I preferred randomized controlled trials and systematic reviews, and I also used the book Hadzik's textbook for regional anesthesia and acute pain management for reference. For the critical appraisal of related literature, I reviewed primarily preventive interventions, and I read about post-anesthetic shivering, pharmacological and non-pharmacological interventions for shivering during neuraxial anesthesia. We included 60 eligible patients in this study, and participants were allocated randomly into two groups. Group O received 8 mg ondansetron, and Group C received 0.9% saline in total volume of 4 ml. These are my inclusion criteria, and these are my exclusion criteria. For the methodology, we use a fishbowl technique for the randomization of the participants to group O and C, and then the study drug was administered by the anesthesiologist 30 minutes prior to induction of anesthesia. Spinal anesthesia was done using a gauge 27 spinal needle at the L3 to L4 interspace, wherein 20 mg of hyperbaric 0.5% bupivacaine was given intrathecally. The patient was then positioned in the Trendelenburg position, and the block was allowed to reach a height of until the T6 dermatome. The shivering was assessed after the completion of subarachnoid drug injection, and the core temperatures were recorded before the induction intervals for the whole duration of surgery using a tympanic thermometer. Shivering was evaluated during the intraoperative and postoperative period by observation of the pectoralis major muscles for more than 10 seconds duration. Outcome is to have a less than 10-20% incidence of shivering in the ondansetron group. And we use the software SPSS for Macintosh version 23 for the calculation and the statistical inferences. The results of the study, Table 1 shows patients' age and gender in all groups. I found no significant difference between age and sex in the two groups. The Table 2 shows the temperature changes of participants included in the study. It could be seen that from this table that the preoperative temperature was a little bit higher among those who were in the ondansetron group compared with the control group, but the tympanic temperature decreased after spinal anesthesia in all groups with respect to their preoperative values. The table 3 shows the incidence of shivering in both groups. Among these patients, a total of there were 51 patients who had no shivering, and this comprised 85% of the population. In this group, 31 31 or 51.7% were from the ondansetron group, while 20 or 33.3% were under the control group. On the other hand, there were 11 patients who had shivering. In this group, those who shivered comprised 18% of the population. Among these patients, 8 or 13% of patients were under the control group, while 3 or 5% of patients were under the ondansetron group. The researcher noted significant difference between the incidence of shivering and treatment groups of patients. Rescue doses were not given on both control group and ondansetron group. So for the discussion, the incidence of shivering was 13% in the control group and 5% in the ondansetron group. So we found that the core temperature was preserved in the ondansetron group with respect to the control group during the intraoperative period of spinal anesthesia. So for my conclusion, prophylactic intravenous ondansetron can lower the incidence of shivering in patients undergoing spinal anesthesia. Thank you very much po.
Thank you very much, Dr. Now may I call once again our chair of our board of directors for these questions.
Okay. Good afternoon, Dr. Yambao. Congratulations for conducting an RCT. No, it's really hard to do RCTs. However, some comments. No, the strength of RCTs lies on its design and minimizing bias, such as selection bias. No, where it utilize blinding, allocation concealment, and randomization. So I noticed that in your method, you said that the attending anesthesiologists administering the test drugs were not blinded to the allocation. Okay, so why is that?
Look, during the approval of the study in the ethics committee, at the beginning po of the research proposal, sir, this was a pharmacological intervention. So during this time, the ethics committee in our institution instructed us that this study should, this ongoing study or the study that I am going to start, I must inform all the attending anesthesiologists and even the surgeons who are the attending surgeons of the patient. So we were required by the ethics committee, sir, to.
So I'm supposing because you give ondansetron as a PONV prophylaxis, and
Yes,
it's unethical if you don't give it if it's already standard of care. So what you can do actually is you can give another set of syringe intra-op, not pre-op. No, so if you gave pre-op ang ondansetron, you give placebo on the intra-op. And next is your sample was you had 26, I think, in the ondansetron group, and then 34 in the placebo, or the other way around. No? Why is it unequal ang randomization?
I think I have overlooked that part, sir. I know that I have chosen the 60 patients and I randomly allocated them in that two groups, sir. I'm so sorry.
Maybe when you did the draw lots sa fishbowl, no, you had unequal. So lastly, with regards to your results, no, I mentioned you had a 26-34 group, but in your results you had a 28 and 34 division. So what is the correct number? Is it 60 sample size or 62?
In the 28 and 32, Doc. So the correct number would be 28 and 32.
Anyway, it will matter, no, because you reported positive shivering in one group as 8, and the other one 3, no, sa ondansetron, no. So if ang correct sample size is 26, meaning 6 lang ang shivering and not 8, it will make your result actually not statistically significant. So you just check your numbers. Thank you.
Thank you very much, Dr. Pruden. Dr. Beltran, your questions, please.
Just would like to verify the conduct of giving ondansetron. How fast or how slow was it administered prior to anesthesia?
During during that time we administered it slow IV push, doc, 1 to 2 minutes, doc, the 4 ml.
Okay. And in your discussion, you mentioned about meperidine and ondansetron. Do they have the same mechanism of action?
No, doc. Actually, doc, no, doc. But apparently, doc, in the papers that I have been reading, meperidine also has actions in the inhibition of the 5-HT3 receptor. But really, sir, the purpose of this study really, it was conceptualized because of my perceived dilemma when I was a resident. Kasi during that time, shivering is really rampant during spinal anesthesia. During spinal anesthesia, and at this time, sir, we had no supply anymore of meperidine in our institution. And I think not only in our institution, but parang na out of stock talaga siya, doc, even in other institutions. So I am trying to find a solution or an alternative to meperidine at this time. But that's why po I was comparing it to meperidine, because up until now, meperidine is considered the gold standard in treating shivering, sir, during spinal anesthesia.
Okay, thank you.
Thank you very much, Dr. Beltran, and not least Dr. Bernardo. Your questions, please.
Yeah. Just one comment lang na. So the ondansetron was given as prophylaxis?
Yes, sir. Yes, doctor.
Have you thought of giving this once the patient had shivering?
Yes, doctor. My research advisor was saying that we can either, one of the ethics committee was saying that, can it be used as a treatment or as a prophylaxis? But in this research, doc, I really chose for it to be a prophylactic one, based also on my mother paper, doc.
Yeah, the reason why I'm asking this is because I was worried also if you give this prophylaxis, what other drugs are being given to the patient. For example, if you're giving this patient analgesics, if you're giving this patient paracetamol, if you're giving all these drugs also may contribute in your findings of having post-op shivering. Okay, that's it. Thank you.
Thank you, doc. Thank you, doc.
Thank you very much, Dr. Bernardo, and thank you very much, Dr. Sarah Angelica. Para kung the colors of your screen medyo nakaka-distract, sir.
Sorry.
That's okay. So we're done with all our 5 presentations. I'd just like to echo the sentiments of Dr. Rosello, Dr. Lunas, and our judges, and congratulate all 5 of you for coming this far. No? At the onset, there were more than 10 who submitted papers, and then it was winnowed down to 8. And finally, the 5 of you. So congratulations, all of you. Hindi madaling gumawa ng research papers, especially this time of pandemic. And yet, 5 of you guys, wow, you did well. You did very well. Congratulations. So the Board of Judges will now do their computations, and while they do that, I'd like to present the certificates to our 5 finalists. Okay, so the certificate reads, okay, so the certificate reads, pwede palakihin yung screen para mabasa natin yung certificate. Ma'am 83 Tech, ma'am, pwede pa lagyan po ng screen, ma'am, para mabasa po ng lahat yung nakasulat certificate. Okay, yata na. Okay. The Philippine Society of Anesthesiologists Incorporated presents this certificate of appreciation as finalists in the research paper presentation for the annual postgraduate course of the Philippine Society of Anesthesiology. This certificate is presented first to Dr. Roland Cajoles. Congratulations, Dr. Cajoles.
Thank you po.
To Dr. Danya P. Chan. Congratulations, Dr. Danya.
Thank you, sir.
To Dr. Cheryl Joyce Tan. Dr. Tan, congratulations.
Thank
To
you.
Dr. Gabriel Angelo Vista. Dr. Vista, congratulations. And lastly, to Dr. Sara Angelica Yambao.
Thank you.
Dr. Yambao, congratulations. And of course, this would not have been the success that it is without the efforts, without the graciousness of our board judges. So thank you very much to our judges for accepting the invitation of the committee for you to participate in such a way in this endeavor. Thank you very much. So these certificates of appreciation will be given to our judges. Right? So masyadong maliit, di ko ulit mabasa. But the Philippine Society of Anesthesiologists Incorporated presents this certificate of appreciation for to the following for having served as judges in the annual President's Research Contest during the annual convention of the Philippine Society of Anesthesiologists. First, for the chair of the Board of Judges, Dr. Emmanuel S. Prudente. Dr. Prudente, thank you very much, Doctor. Dr. Jose G. Beltran Jr. Dr. Beltran, thank you very much. And last but not least, Dr. Serafin L. Bernardo. Dr. Bernardo, thank you very much. Thank you po talaga sa inyong tatlo. Okay, so now we'll wait for the computations of the judges. So we'll wait for the announcements. Once the results are tallied and we already have the final tally results, we can announce the winners. So while waiting, I'd like to acknowledge the virtual presence of our immediate past president of the PSA, Dr. Benjamin Valera. Dr. Valera, good afternoon po. Thank you for gracing our event. We have 166 participants. Thank you very much to our participants. Thank you for joining us this afternoon and for supporting all our presenters, mga fans ni Dr. Chan, ni fans ni Dr. Yambao, ni Dr. Vista, Dr. Tan, Dr. Cajoles. I'm sure you're all excited to know what the results are.
Dr. Madarang, while waiting, may I?
Yes.
On behalf of my fellow judges, Dr. Pai Bernardo and Dr. Jose Beltran Jr., First, I'd like to again congratulate everybody, all the finalists for planning, conducting, and writing your manuscripts. Especially this, as mentioned before, no, this time of pandemic, it's really an achievement. And secondly, I'd just like to remind everyone that the audience and the participants that the judging for today is 20% for the oral presentation. So most of the scores actually came from the prejudging of the manuscript. And lastly, I hope you will not take offense on the questioning and comments of especially from me, no? Ganito lang talaga ako magsalita. But hope you take it as a constructive criticisms to improve your paper. Okay. So I think we already have the Dr. Madarang. Okay. Is it okay?
Yes, po, Doctor. Yes. So Dr. Pudente will now present to us the results of their tally and to announce the winners of our contest.
Okay. Okay. So for the third prize, we have the paper on, let me double check. The scores are very close actually. For the third place, we have the performance on mini-cog screening test as a predictor for post-operative complications in older orthopedic surgical patients admitted in a tertiary hospital February 2020 to October 2020. That's the presenter, Dr. Cheryl Joy Stan. Congratulations. Okay. So for the second place, yes, virtual applause, please. Uh, the second place, no, with a difference of just 0.3% from the first place, we have the first presenter, a prospective study on perioperative patient satisfaction of patients undergoing elective surgery from March to June using an ASA patient satisfaction questionnaire, Dr. Roland Cajoles. Congratulations. Okay, for the first place, we have with a score of 115.6. We have left head rotation as an alternative to difficult tracheal intubation, Dr. Danya Pichan. Congratulations, and congratulations also to Dr. Gabriel Vista and Dr. Sarah Yambao. You will also receive consolation prizes. Okay, I'll turn it back to you, Dr. Madarang.
Thank you very much, Doctor, and congratulations to all three, all five of you. But special congratulations to the top three, and congrats, Dr. Danya Chan. Well deserved, well deserved. Thank you very much. And once again, with that, I'd like to, I'm supposed to introduce for closing remarks, but nagkaroon yata ng problema with the presentation. So I would just like to once again thank every one of you for attending. Thank you very much to all our presenters. Thank you very much to all our finalists. Thank you very much to our board of judges for the event. And hopefully, I will see you again next year for yet another annual research contest. And congratulations to the organizers of the event. And congratulations to the subcommittee on the annual research contest. Thank you very much, and let's enjoy the rest of the convention. Maraming pang events na gagawin. Ang galing naman if I may just say, ang galing ng platform ulit ngayon. It's same as last year. This like may magandang lobby, tapos pwede kang pumunta sa loob. It's an enjoy. Please, everyone, please enjoy convention this year. So with that, thank you very much, and we'll see you.